Welcome back to Soffer Longevity, or what we affectionately like to call the Doctor's Lounge, where everyone's invited. This week, we're opening the doors to one of our most provocative conversations yet. The rules of preventive medicine may be changing faster than most people realize. Weight loss shots are becoming pills. Your microbiome or gut bacteria may be influencing far more than digestion. And proteomics, or new proteins in the blood, can detect disease maybe even before they've happened. The conversation is rapidly shifting from diagnosis and treatment to interception and complete prevention. Tonight, we ask the question everyone is thinking, but few physicians are able to discuss together out loud. Are oral GLP-1 therapies the beginning of a new era where cardiometabolic medicine becomes scalable, convenient, and preventive? New oral formulations and next-generation agents are beginning to challenge the assumption that injections would dominate the space alone forever. Have we underestimated fermented foods as a serious player around inflammation, metabolic, health, immune signaling, and possibly long-term cancer risk reduction through the microbiome? Emerging research continues to connect fermented foods with greater microbiome diversity and immune effects, although the science remains early. And this all in one episode. So stay tuned as Dr. McLeod, my favorite Yale-educated functional medicine physician, and the folks at Longevity AI, our keynote sponsors, bring you this week's episode. So the fun thing about these podcasts, we get to talk about, like we're at a doctor's lounge where we talk about our personal stuff, and you're pretty open with your personal stuff. I've open book. But I know that you have had some experience with some of the oral GLP-1s, the oral Ozempics, Mounjaro, Wegovys. Tell me your thoughts. How's it been going? And let's hear your experience.
Well, I've started the Fundeo, so that is the oral GLP-1, but it's the molecule form and not a peptide. So that's why it's different than like the Wegovy pill. So I was giving it a chance to see how I would react to it compared, because I have taken an oral Wegovy. It was Rybelsus at the time, and I didn't feel very much with that. So
because it was like not so strong, right?
Not so strong. It wasn't. It seems like
the first real oral GLP
exactly
one, but it really never got any movement. It was way before Ozempic.
Yes. Yeah. It was. I can't remember how many years ago, but it's been a while.
Yep.
Yeah. So when Fundeo came along, I was just excited to try it and see if it would be a good way to kind of transition off the injectables.
So there's a lot of stuff swirling around the internet and through my patient population around that exact thing. So people are like, okay, great. I lost some weight, maybe goal, maybe close to goal, maybe even over. I've lost weight on the GLP-1s, whether it's tirzepatide or semaglutide, whether it's brand name or in some cases compounded. Yes. I've lost the weight. Now what? Yes. Am I on this for the rest of my life? Because it doesn't matter what it is, whether it's been cholesterol medications for many years. People don't like to hear that they're on something for the rest of their life. Understandable. Yeah. So the idea of a transition is being explored, going from the injectables, which people don't like as much, mostly because of, two reasons: needles and cost.
And also carrying it. I mean, like if you're traveling and this, you have to make sure it's like temperature controlled, so it's a little harder to travel with it.
So all things convenience don't necessarily add up as much in the injectables. So they're dramatic, it's great. You don't have to remember every day. Compliance maybe is good. But now you need an oral. So the oral versions that came out are really twofold. So there's the oral semaglutide, which is basically the same thing as Ozempic or Wegovy. It's just bioabsorbed and absorbs pretty well.
If you give it time.
Right.
Yeah,
You have
that's the whole thing with it, is that you do have to give it time.
The holdup with the semaglutide oral is you have to take it like in the morning, has to be in and around some water and a certain amount of water. So there's there's some timing issues. And then there's the Foundayo,
Yes.
which no one can say their name.
No,
Or
the actual name,
yes. But the Foundayo version, which is a new GLP-1, which
Yes.
we really don't have in an injectable form exactly. So it's not 100% sure how people are going to react to it. And but there is no issue around timing, right?
No.
You can take it whenever. It's not a certain amount of water. It just seems to be you can take it, and it's equally, at least equally as effective, right?
It's because it's a molecule and it's no longer a peptide.
Right, because it's bigger amino acid chains. It's bigger. It's.
No, it's actually smaller than the.
Oh, is it smaller?
Yeah, because it's not a peptide chain. It's just a small molecule. So that's why the absorption's so different.
It's a completely different molecule.
Yes.
This molecule is not a peptide.
Nope.
Which is a small chain of amino acids.
Yes.
It's a different structure.
Yes.
And it is seemingly working in the same ways. I think it's the attain, maintain studies that showed specifically that it works, really well, maybe even in transition from injectable to non-injectable. You decided to take the Foundayo and not the more studied semaglutide oral form. So why was that? Let's start with
Just because I did try the oral semaglutide previously years ago, and it did not work for me. So,
but not oral, not in the form that it is today.
no.
Okay. So you didn't like it then, therefore you're like, listen, maybe I'm going to try something different. But the Ribelsis or the different forms that were there before are now...
They're different because they were able to attach something else to the peptide that is supposed to help with absorption. So that is the Wegovy pill.
Right. So the Wegovy pill, let's just call it right now, seems to be really successful. And the side effect profile is pretty low.
Yeah, pretty much the same as semaglutide, just the injectable.
Right. Maybe even, I know that it was, the side effect profile thought to be maybe even lower than the Foundayo, but arguably very similar. So pretty well tolerated. You can take it, not take it, and then you get into this other thing called microdosing, which is an unknown pharmacokinetic. Like we just don't know what that necessarily means, but mentally people are like the idea of like a little somehow is better than...
Well, for some people, when they take that, like the bigger dose of tirzepatide, they seem to get like the side effects. But when they split that dose, so let's just say they're on 10 milligrams. So instead of taking the 10 milligrams all at once, they take 5 milligrams and then in a couple of days take another 5.
At the cost of maybe not getting some of the benefits.
We don't know. Yes.
Right. Maybe the weight loss, maybe the long-term cognition, even cancer reduction, which recently came out, which is magnificent. It's funny, when we first were giving these GLP-1s as a class, there was this concern of like, pancreatic cancer, is this something that could be...
Thyroid cancer.
It seems to be the opposite. It seems to be, there's real data now to suggest that even people that have diagnosed cancer, particularly those that have obesity worsening their cancer, do better.
Yes, on the medications.
On the medications.
Yeah.
So not only is it not showing a real bump in cancer now that it's being used by millions of people, it seems to reduce the cancer ill effects, if you will, or the... people are not getting to the later stages of cancer that are on the GLP-1s. So it's these crazy side effects, not side effects, these crazy things that happen unexpectedly once we start putting things out in a population. Sometimes it's negative, a thing gets to be stopped, but in this case, it's more positive, which explains this phenomenon that makes it some of the more prescribed drugs in the world.
And that's why they're moving on to making more types of them. So like going on to retatrutide, and we'll see how that works.
Well, that's an exciting one. We have a research division here, and we are very hopeful to be involved in some of that investigational stuff past, so I may not be able to talk about that as easily in some of our future podcasts, but it's so exciting because Retta is like the name that the gym bros are using right now, using experimental versions that are probably for non-human use and taking it for whatever reason versus controlled studies that are going to show hopefully lots of benefit. But let's not go on that tangent just yet. We're talking about orals.
Yes.
Oral GLP-1s. And we're talking about transitioning from having lost the weight with the known injectable pharmacokinetics to now an oral pharmacokinetics. Keep saying it's a big word that really means like this is the amount of medication that seems to work well in human bodies.
Yes.
So we have this ability to start with a starting dose. Now you started with a starting dose. What were your numbers and where are you going to go with it?
So I did start with the initial dose that they recommend, but it seems like it's just very, especially transitioning. I think like I'm already kind of like my body's used to a GLP-1, so I don't think I needed to start, there and stay there for the full month. So I've been kind of escalating it a little quicker than is recommended. But again, I'm doing this, as an experiment on myself.
Right, right. Nothing better as a doctor. I know the few times that I've been able to experiment on early release of FDA-approved drugs, the better of a doctor I was for patients. So it's great that you're doing that, but it's even better that you're going to find the right dose that's right for you. And that everybody really needs to do this with some sort of medical supervision because this idea of like microdosing and taking things without any kind of physician supervision.
Yeah, no, it's definitely recommended that you work with somebody who knows what they're doing so that you if there are any side effects or anything, you catch it early and not waiting until, something happens.
So you're on your Fundio after having lost your weight on
tirzepatide.
On the tirzepatide molecule, the peptide. So there's a little bit of a transition because it's not the same, but it's the same GLP that's being attacked. And therefore, we would expect that you will be able to maintain, because you're going for maintenance.
Yes.
Right? Which is really kind of the thing, because a lot of the studies on the orals, on the oral GLP-1s, is related to weight loss.
Yes.
But the bigger idea, I think, is like get everybody to lose the weight with the injectables, at least for now, because we know they work
better.
And then, and people like that idea. They like the idea of, okay, I'm going to be on this, then I'm going to go on this, and then I'm back to my, birth weight, or whatever, my natural, perfect weight, and everything. There's something right in the world when we kind of fix ourselves. So the truth might be that you will need the oral GLP-1s for a very long time. There may even be a situation where you need the oral GLP-1s till maybe that doesn't work. You have to go back on the injectables. Yes. We're not sure about any of this.
Exactly.
But I've already seen some patients that went from an injectable for a relatively short period of time, meaning under a year, onto the orals, now weaning off after significant lifestyle changes.
Yes.
For me, I was on, I didn't tolerate Ozempic. I tolerated Mounjaro, and I did really well on that tirzepatide molecule. And I think that over time I could use a little help in maintenance. So far, right on the cusp of maybe having gained a couple of pounds.
So maybe you want to join my experiment.
I do. I'm just trying to figure out, do I do Fundio or do I do the Wegovy pill?
Yeah.
And
maybe you should try that. I'll try this one.
Pill and we'll see how it is. Yeah.
Exactly.
Well, I think that's a great idea. We'll talk about it in the next couple of podcasts. Give ourselves 4 to 6 weeks or something and see what happens. Good idea. So anyways, just to summarize, so there's the Wegovy pill, there's Fundio. They're two different molecules. They both work pretty well. They need to be individualized. And they can be primary. People can go directly on it if they never want an injectable. but it's not as powerful.
Yes, they've done a study comparing injectable semaglutide to the orals, and it wasn't. Yeah, the difference wasn't that much. The difference is more between tirzepatide, but again, tirzepatide's a GLP-1 and GIP, so that's why it worked better than the oral GLP-1s.
And everyone should know that the recent data is very clear that GLP-1s are not just good for they're well beyond the weight loss. It seems to be profound, maybe anti-inflammatory effects. It seems to be really good. There seems to be improved cognition, improved response to cancer treatment at the very least, if not prevention of other diseases that are out there. Yeah. So we really haven't found a major flare-up of something that would say for us not to be recommending it, but you and I have learned so much that you absolutely need to go to a doctor that has had experience with it, because they could have read whatever they wanted. It could be a principal investigator on some of these studies, but until you have the experience with a few hundred, if not a few thousand of your own patients,
it's different.
And get your dosing right. This, it's an interesting thing, talking about like the doctor's lounge. I'll never forget, I had a real good conversation at doctor's lounge once about statins. And the debate was in those days like, well, I want to start a statin, but I don't want to go to the main dose. I think maybe it was Lipitor.
Okay.
So I want to do Lipitor 40 and not the 80 that was particularly studied, or I want to do 20 and not the 40. And there was this idea in my brain of like, well, let's start slow and work our way up. Except that the side effect profile didn't care which dose you were at. You were going to get the side effects almost no matter what. But the potency, the effect that we were trying to give this to people so to reduce heart attacks and strokes, atherosclerosis, lipid levels, to reduce all those things, the lower dose was much, much worse. So you really weren't doing anybody a service. You were giving them less potency with an equal amount of side effects. Now, I don't know if that's the case with GLP-1s, but it's just something to keep in mind, because when we do these studies, we do them in usually blinded ways around different doses. And that's how we come up with what's the human dose. What's the right typical human dose. Everybody's a little bit different. That's why we all have individual doctors, and we don't like go to some sort of central doctor. We have an individual doctor that individualizes, and which is why your practice is so great, because it's really individualized, precision, functional medicine, and you kind of have to wrap all that together. So that's, I think, a good summary of where we are as of June 2026 regarding understanding the oral GLP-1s, particularly as it pertains to the transition from the injectables. So we had a couple of other topics we wanted to go over today. What was the next one you had mentioned would be?
Fermented foods.
Oh, that's a question we get a lot.
Yes.
Talk to me. What are your thoughts about it?
So fermented foods, I think, is a good way to introduce like diversity to your microbiome. And
your gut
bacteria. You do want a diverse population as much as possible. And so that's really how we get those gut bacteria through fermented foods. So there's a whole bunch of different types of fermented foods, depending on what person will, what they're willing to eat. But it's just to increase your gut diversity.
So give me your top few fermented foods that you like or you recommend.
Well, recommend usually the top number one is usually yogurt, because that's where everybody, they're not averse to it or saying like, oh, I don't really want to eat that. Yogurt and cheese. So those are the top two. And then we can start going into the other types of fermented foods like kimchi or kombucha or those kind of things.
Sauerkraut?
Sauerkraut, yes.
My favorite. Favorite. I had the best sauerkraut, probably the best food mix I ever had that I never thought would be so delectable was sauerkraut and the doughy pretzels in Germany.
Oh, interesting. Okay.
That was like, it's a staple. It's like French fries, you'd get this sauerkraut and these, like, they just make those big pretzels, those So delicious. But the sauerkraut is a very staple food in, in Germany. I'd be curious to see, like, do they have improved microbiomes? Do they have better, similar to, what kimchi is Korean.
It's Korean,
right?
yes.
So I'm wondering, do those populations do better? Do they have less?
Well, it seems like a lot of the populations, because that's how they also preserved foods. So that you will find in the different, cultures, their version of some fermented foods. So it's I think it's less here, just because we don't do those old ways of preserving food.
More sort of processed
and
chemicals.
Yeah.
So what is it about, do you think, the fermentation process that makes it so healthful?
Because you're adding bacteria. So you are kind of doing like a precision growth of certain bacteria, because you obviously don't want any bacteria to grow. So that's why in all those different processes, they kind of control like how the temperature is and, what starters they use so that you can grow certain bacteria in those foods.
So speaking of starters, again, it's Doctor's Lounge. We're allowed to say anything. I am like a little crazy right now trying to make sourdough.
Okay, there you go.
You have to have the starter packets.
So sourdough technically is fermented, but because of the baking process, you do kill off the bacteria that are growing, but it doesn't matter because your immune system still kind of will react to the bacterial fragments.
So a sourdough with sauerkraut.
There we go. Add some yogurt to that.
With some interesting. So I never thought. So sour, is it the word sour in there for a reason? Maybe it
because the acidity. Yes.
So does the acidity also play into the gut microbiome?
Well, that's just how those bacteria decide that's what they make. So that's a lot of the fermented foods will have those sour notes.
Is that different from pickling?
Yes. Yeah. So pickling, you are adding the vinegar to it, and that is your automatic acidity. So it's not allowing any bacteria to grow. So you can do like quick pickling, you can do like longer pickling, but yeah, you have already added the acid, so you kill pretty much anything that is trying to grow. Interesting.
So your top foods, yogurt, kimchi. What was the third one?
There's cheese. Your
cheese.
If
is any cheese that's better than the other?
If it's a traditional cheese, so it's made with a starter and all that, but I wouldn't recommend like the processed cheese because that would not contain anything.
Like a slice of American cheese.
That not
a cheeseburger is probably not.
That's not it.
Like
blue cheese.
Now, do you get like when your microbiome? Because you as my personal functional physician have me on the probiotics, and I feel a GI difference when I take them, and for a period of time, and then I just have them on my in the bathroom, and I remember I don't take them daily. I take them periodically. But it seems like everything kind of works a little bit better. Why is once the flora grows?
Yes.
Does it stay like?
No, it doesn't. That's why you've like having fermented foods. It's usually on a daily basis. You do try to have them daily, and if you're not able to get in the 3 to 5 servings of fermented foods a day, then that's when I recommend a probiotic. Yeah.
Based on what you're eating that day.
Based on what you're eating that day.
So the bacteria so quickly overgrow?
Or start to go down in their numbers.
What about people that have to take antibiotics for, say, some sort of an infection?
Yeah, that's the problem with antibiotics is that you're going in, you're killing everything, the good, the bad, everything. So I do recommend them take probiotics while they're on the antibiotic, but just kind of shifting when they take their antibiotics compared to when they take their probiotics. But I do like them to continue that through that antibiotic course and then for weeks after, just trying to get their microbiome back.
So interesting. So you don't stop, per se, antibiotics in your practice. You just orient it around probiotics. And
Yeah, I definitely only give antibiotics when I absolutely have to. I don't like giving it for colds.
right, viral.
It's
most
viral.
of them are viral,
Yeah.
right.
But yeah, so there has to be a really good reason for them to take antibiotics.
Super interesting. Okay, so from a fermented foods perspective, I think we identified a couple of good ones. The idea around yogurt is also something I've changed since sort of talking to you. I happen to love Greek yogurt and not one that ever really had the sugary yogurts, right? The ones that have
all the flavoring, and if you're trying to make it taste like dessert, then it's probably not going to work as well as just a plain yogurt.
Right. So it's got to be kind of plain yogurt.
But you can put berries in it, and you can put
Right.
other stuff to make it.
Add them yourself, so you've got kind of control of that process.
Yes.
So the yogurts, kimchis, if you can,
If you like it.
yeah, I happen to love it, and I'm going to add sauerkraut just because.
There we go, sauerkraut.
You can do it, and good cheeses, which is the way, say, for instance, the French. Maybe that was part of the French paradox. The French paradox was always this idea that, like, it seems like even though these French that were studied were smoking like fiends, they weren't getting as many diseases, and their mortality was fine. You imagine someone outside of a cafe on the Champs-Elysees having
a cigarette.
a cigarette. But they also would have like a little wine and cheese, and people were like, oh, the wine must be the good part.
Okay.
But
Maybe it's
not.
the cheese.
Maybe it was the cheese that was helping them, because that's part of their dessert, a bigger part of their
They do
diet.
they do eat a lot of cheese, don't they?
Yeah. It's a very common part of their meals.
Yeah.
So because the wine part of it has not really, and that's a whole episode unto itself. But the best alcohol in the human body has pretty much been determined to be zero alcohol. Right next to that is a very mild amount, right? A mild, a low amount, and then you get into that J curve where it spikes up with having more of it. So, so the idea that it was the alcohol maybe negating the effects of the smoking is probably not true. Maybe it was the cheese. It's interesting.
That would be a
interesting
good
to look at that study from those days when we were. When we were looking at it alongside, well, maybe it was the resveratrol, which that really hasn't panned out in human data. The essence of the grapes trying to lead to red versus white, which right now we really don't recommend either. We recommend no alcohol, but if you're going to take it in limited, in limited amounts, so less than a glass a day,
And how big is the glass? Because
Exactly.
because there we go. Might be too much.
Right. Okay. Well, those are good tips. Okay. Well, I think we covered kind of the fermented food questions. A lot of these are coming from questions, so I encourage everybody at home to, write us questions. We'll get to as many of them as we can during the, upcoming podcasts. So those are two of the 3 or 4 things we wanted to talk about today. One of the things I read that I wanted to talk to you about is this idea of proteomics. I'm not sure our producer would love it because it's a little bit on the cutting edge. It's a little bit maybe too scientific, but let me just summarize what I took out of this study that was also, by the way, on the front page of the New York Times, I think 3 days ago.
Okay.
Basically, there are 14 proteins that were identified in blood by accident.
Okay.
Complete accident. It's called proteomics. So proteins in the blood that then were sort of mass recognized, I believe, using mass spectrometry, which is a way of quickly looking at a lot of blood. And they found that this protein cluster was able to identify lung cancer 5 years before it actually happened. 5 years before we were able to diagnose it now.
Okay.
In its earliest stage. So it's basically the first inkling into a pre-screening or a real preventive type of environment that can, by the way, lead to some treatments. Those treatments in the pre-screening way, you know, there's a lot of excitement around a particular type of vaccine, which is, I know, a charged word, but let's just call it immunologic treatment for something that hasn't even happened yet.
Yeah.
And how exciting is that? Because so frequently we're dealing with, we used to deal with cancer when it was stage 4.
Yes.
Because that's when we know you would have it. Too late, maybe you'd get a few extra months. Then stage 3, now you're talking a few extra years. And stage 2, and now actually before it happens, is now being discussed. And it was even more interesting how it happened. There was a study called the CANTOS trial, which is a cardiac trial, which I knew of as a cardiologist. I knew of this, and the study failed. It was one of these blah, 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 a MAB, you know, like a immunologic treatment that was designed to probably, the hypothesis was to reduce heart attacks and strokes via atherosclerosis. Wasn't good. It wasn't a good study. It was a big study. It wasn't a good study. But you know what they found out? That there was like almost no lung cancer in those patients. So they were just checking stuff like a good study would do. So they're, okay, how many heart attacks, strokes, how much cancer, how much, you know, arthritis, diarrhea, you know, you hear those commercials, they're like,
with all the,
how did they find out that they cause nightmares? Because they really ask for all of these things. So this thing was looking for also had lung cancer. I didn't know it was going to be a thing. Really did not know. It happened many years after the trial. But they had all this blood, and they looked at it, and they were like, wow.
There's something here.
That's stopping lung cancer. So these brilliant researchers, and we're talking about like, I want to say it was dozens of countries and hundreds of thousands of patients. So it wasn't just one lab somewhere. This was a very large trial, and it was really looked at deeply. And they found that there's this highly significant, you know, reduction in lung cancer.
So
and now, because they know what these proteins kind of mean, there's this hypothesis that has to do with interleukin B. And I don't want to get, immunologically, we can kind of give a vaccine against it. And by the way, it wasn't just for smokers. It was for people that, you know, may not have had smoking as a risk, and or particulate matter, you know,
asbestos and this. And
you know, air quality things like that. It wasn't. It's just a blood test, and so there are companies that have been using this kind of technology for some time, like the ones that make Cologuard. They have, I think it's called CancerGuard. CancerGuard. There's one before that it's even bigger.
Gallery.
The Gallery test. So these tests have been looking at certain proteins. And you and I have been doing, you know, I'm sure when you were at your Yale hospitals, you know, you would check a CA19-9 or a CA, or there were studies that we'd look at proteins, but those were advanced proteins of the cancer, not of the milieu or the substrate that would become cancer. That's the big difference. And there weren't a lot of those. There's only a few of those, and they were non-specific. So this one's specific, this one's early, and this one could potentially be treatable, and that could be where lung cancer is a thing of the past. And it's so exciting that these cancer studies are there, because we talk about longevity, and that's why this is called the longevity, Soffer Longevity. It's because there's 3 things that kill us. Just to remind everybody, you know, heart and stroke, right? Heart, cardiovascular disorders, cancer disorders, and neurodegenerative. Those, if we can make an impact on those 3, we can, you know, not have elderly periods, but welderly periods, right? So that's the goal. That's the goal. It's not to live forever. It's to eliminate those things that we know get us, so that we're not struggling in our last, you know, 10, part 15 of our years, life. So it's very exciting. It was those of you who want to Google the New York Times, it was on the front page. They did a pretty good job. It was a little cartoonish. It wasn't I don't even know if it was this involved in terms of the discussion, but it's getting really a lot of my colleagues are super excited about where this takes us. And by the way, I think you need AI to do this because look at those, all those blood tests and figure out the proteins and their structure required AI. So AI is just taking things that we thought were good and putting them into play all of a sudden. So it was super. How frequently do you get the gallery when in your practice as a functional medicine, as a longevity expert? How frequently?
You can do it yearly just so that you're checking on a year. So it's the same idea as like when you're doing your other cancer screenings, then this is just kind of just an added layer.
Because you would catch something earlier.
Early, yeah. And that's the whole point of this is that if we can catch something early, it's most like
the whole point is to prevent it.
Exactly. Yeah.
Right now, those tests tell you if you have it.
Yes.
Right?
Yes.
The goal, I should say, maybe not the whole point, but the goal is to prevent it from ever happening. And that's what this one does.
This lung.
That's what this lung.
Yeah.
This 14 proteomics.
Yeah.
But yeah, but you routinely do that, and I think that's super. I think that's a super strategy. I know I did my whole body MRI, which is very controversial, but I did it so that I have a baseline where it made me feel really good too. Oh, geez, those stomach aches I were having is not like advanced cancer.
Yes.
It is that I should have been eating more fermented foods.
Yeah.
But the idea to do that and then periodically do it for me makes sense. But that's an individual thing, and for people that want to just go to one of these Prenuvos or these places that just do it and don't have a doctor around it, can find themselves very worried afterwards. And stress, as we know, can be the thing that gets you. So you don't want to do it without like a doctor saying, okay, you don't have to worry about this. Is what we call an incidental anoma in the doctor's lounge. That's what we would call it. Oh, I saw a little blip here.
And we'll either watch it or we need to investigate further. One of the two. Yeah.
Right.
I have that with a lot of patients that do the lab testing. Kind of same thing. They get the lab, like a really extensive panel, and then that's it. They don't know what to do with it.
And you have to really, there's a couple things we say in the lounge. One is never get a test you're not ready to act on.
Yep.
And, don't go down a rabbit hole that, you become too committed to. We don't really say that one because that's not a good of a metaphor. But you know what I'm saying? Like it is. I can't tell you the amount of arguments I've had with my other cardiology colleagues. I'm like, I don't think I want to get a cath here. And the answer is because the patient isn't having symptoms sometimes. If they end up with, say, an angiogram that leads them to a stent, and the stent was marginally necessary, and you put in a stent and there's a complication around the catheterization of the stent, which we see, it does happen. You can do a cath and inadvertently shear an artery, or you put in a stent and it closes, and now person becomes a cardiac patient that wasn't. You really have to trust the science of your doctor as well as their instincts, not to mention their motivations. So, it's just important to get a relationship with whatever physician that you're
that you choose.
Putting your reliance on, your trust in. So, which is one of the great things about the podcast. So for me, like these things are putting a library together for our patients when we see them. So you're not really sure about why we're telling you to to have sauerkraut.
There we go.
Go to the podcast and you can listen to it in a comfortable setting. And I think maybe there's a time where all doctors will have this, and they'll kind of put everything
in a library,
thoughts, their perspective into a librray. Not a bad idea. Or yours, they can use ours.
They can use ours, yes.
More viewers. Okay. Well, that's those were three kind of fun topics that we wanted to talk about. I know that next week we're going to talk about some of the things that you really wanted to mention, which is rapamycin. Metformin use, these are real longevity trends, and berberine, which also have shown a lot of promise. And we're going to talk about those next one of our next episodes. And then I also wanted to go over any questions that people might have had from last segment, which we focused on a variety of things, but creatine being one of the major ones. Did you get any questions or things come up in the last week about?
It's mostly dosing. That was really the question, because everybody's like, well, I don't really know, should I be taking 3 or 5 or 10 or 20? So, but it really comes down to, to the patient, what we're trying to achieve. So that was, it was mostly around dosing.
Right. So just the answer is somewhere between 3 and 5 in
sometimes
conjunction
10,
with your doctor, unless you're going to load. And then if it's going to be higher, it should be with...
you should be, discussing it with somebody and not just.
But an extremely safe drug with the safety. I mean, all of this comes down to risk.
And benefits. Yes.
Benefit. I don't think we do anything in medicine, but every day just discuss risk benefit, because we don't know all the answers, but we do know the statistics and the science, and it comes down to risk benefit on an individual patient.
Yes.
What may be a risk benefit ratio in one person might not be in somebody else.
Yeah.
Yeah.
And that really is what we do all day long.
Before we go, here's a look at what's coming up next on Soffer Longevity, the doctor's lounge for everyone. Next episode, we're diving into some of the most talked about and surprisingly under-discussed topics in longevity and preventive medicine. First up, sunscreen may be entering a new era. We're unpacking BEMT, the advanced UV cream already available outside the United States for more than 20 years. Many believe that this could change the skin protection game forever. Why has the rest of the world had access while the U.S. has lagged behind? Does broader spectrum protection actually matter for aging and skin cancer prevention? And what should patients know before the hype outruns the science? Then we're going to shift into one of the biggest conversations in longevity: Rapamycin, Metformin, and Berberine. Different medications, different mechanism, one enormous question. Can drugs originally designed for entirely different purposes help extend health span? We'll explore what the evidence actually shows and when enthusiasm may be getting ahead of the data, and what physicians are really thinking behind closed doors. And we're not done there. We'll also circle back to today's conversation and answer the follow-up questions that always come in after the microphones are turned off. The practical questions, the skeptical questions, and the ones patients had wished they had asked while in the room with their doctors. No hype, no miracle claims, just experienced physicians breaking down what matters, what's promising, and what still needs proof. So join us next time on Soffer Longevity. You won't want to miss this one.